Our next speaker is the last speaker, Dr. Pravin Krishna, who needs no introduction. He's a cornea and refractive head at LV Prasad Eye Institute, a innovative surgeon and a innovative speaker with amazing presentations. Over to you, Dr. Pravin.
Thanks a lot, Harsh, and also thank you, Chinmay, for speaking. Can you hear me all right? Yep. Okay, thank you for speaking about PRK. The reason why I say that is because typically in most meetings, even at AIOS, PRK is one talk in a session about refractive surgery, and usually is not given a lot of precedence or importance. But it's very rare to have an instruction course on surface ablation by itself. So actually, good job, and thank you for bringing this up. I'd like to speak to you about PRK, or what is also called advanced surface ablation. And typically, you've heard in the earlier talks how PRK or surface ablation is supposed to be limited only to a small group of patients who are not suitable for other forms of refractive surgery. But what I want to share with you is to tell you why we've actually transitioned from PRK as a secondary procedure to PRK as the procedure of choice for the majority of our patients over the last several years. Again, going back in time, this is a patient that actually I always share, and this is a patient that I still see to this day. This was a patient seen in 2002, if you look at the screen on top. And she was a young doctor who came in for LASIK at that point of time. Then I think we were operating on the Zeoptics system along with the Zeoptics XP microkeratome. So she underwent a microkeratome LASIK about 20 years ago, uncomplicated, flaps were thicker in those days. She had a very good residual stomal bed, normal topography, maybe slightly on the thinner side. But then I saw her when she came back about 5 years later, and she started to develop some astigmatism and some inferior ectasia. And before cross-linking became more available, 8 years after surgery, she developed full-blown ectasia. And again, this is just one patient of several that you tend to go back and look at and wonder, what did you do wrong? Because if you probably did this surgery again, you probably would do a LASIK, maybe with a different microkeratome, but still you would expose yourself to the risk of ectasia. And like Chinmay spoke to you about, post-LASIK ectasia is a real issue, especially because of the fact that when he mentioned the Randleman risk scoring system, one point that is very interesting is the fact that being young is an automatic increase in the risk score, and most of our patients are actually quite young. And the average age at which we do LASIK in India is about 23 years. The average age at which LASIK is done in Caucasian population is 36 years. And being 23 already gives you 2 points in the risk category. Lesser than 1 is category 3 risk. And from that perspective, automatically surface ablation is a better procedure than LASIK. And there are several case reports, at least 3 that I found, where patients who had normal topographies underwent LASIK in one eye and PRK in the other eye. They developed ectasia in the LASIK eye, did not do so in the eye that actually had PRK. And if you look at literature of ectasia and associations with procedures, obviously the most common correlation is with LASIK, where you have the highest reported incidence or number of cases after surgery. SMILE is starting to be reported more recently, which is again unfortunate. There are very, very few case reports scattered in the literature about PRK and ectasia, and if you look at them, most of them are actually in patients of keratoconus where there was pre-existing ectasia before. So again, what causes ectasia? And we really do not know what causes ectasia truly, but then again, it seems as if LASIK and SMILE do increase the risk of having ectasia, whereas PRK doesn't do that. So this is a very interesting slide because it actually shows you the journey at LVP, and from 2010, where 70% of our laser procedures were all LASIK surgery, about 27% was PRK, 5% was phakic IOLs. We've transitioned in 10 years to about 70% of PRK, 25% of LASIK, and a small percentage of SMILE and phakic IOLs. And this is a journey that probably is also because of the previous slides that I showed you, but also because of the fact that the outcomes that we've had with PRK have been fantastic. So this is about 10,000 eyes data, 5,000 patients who underwent PRK, much larger than most other published series, with at least a 1-year follow-up. Majority of our patients were in the error range of 3 to 6 diopters. They were a significant number, 5%, who had more than 9 diopters of refractive error. Average age of all these patients was about 25 years, and the mean spherical equivalent in each of these four groups, we divided them into 0 to 3, 3 to 6, 6 to 9, and above 9, was 2 diopters, 4.5 diopters, 7.5, and about 10.3 diopters as well. And when we looked at the outcomes of PRK in these patients, the outcomes actually were quite comparable between these three groups in the relatively lower myopes. And you'll see that the accuracy of correction of the uncorrected visual acuity, 20/25 or better, 99% of patients actually had that visual acuity up to 6 diopters, and between 6 and 9 diopters, 97% were better than 20/40. And this is also because some of these patients did not correct to 20/20 before surgery as well. When we looked at the accuracy of correction, within plus minus 0.5, 98%, 98%, and 95% up to 9 diopters, which is actually better than most other refractive procedures, including LASIK or phakic IOLs as well. Stability too in the three groups we found was equally good. Up to 12 months, there was really no change in the refractive error once they reached their final refractive error or final vision at the end of 1 month after surgery. So what about really high myopia as well? So we've had experience in operating PRK in very high myopes. An example is here. This is a minus 11.5, minus 2 refractive error. Patient was corrected to 20/40 before surgery, and she had a shallow anterior chamber, so we can do a phakic IOL. We did PRK for her. This is her about 6 months post-op, and she was plano 20/20, and she continues to be this even several years after surgery as well. So PRK seems the fact that we can expand the correction range of PRK beyond what we typically would do or what is advisable of up to 6 diopters. And we found that when we looked at our patients who had myopia of greater than 9 diopters, we found that the accuracy of them being within plus minus 0.5 was close to 80%, which still is exceptionally good compared to any refractive procedure in this quantum of myopia. And within plus minus 1 diopter, there were 93% of patients. The mean sphere in this group was minus 9.5. Mean spherical equivalent was about 10 diopters, so very high myopia, who underwent PRK with at least 1 year follow-up. So when we compared this with patients who had myopia of 1 to 3 diopters, the correction accuracy was as expected, slightly lower, but the stability was equally good in both these groups, which again negates the worry that high myopes tend to regress more after PRK compared to lower myopes. When we looked at haze again, haze certainly is something that you will see. And you look at these bars, only the red actually is severe haze, which is impacting vision. Several patients did have haze in the early post-op period, but then towards 12 months, most of these patients did not have any haze. And the only ones who had severe haze, who actually required intervention, were mainly in the group between 3 and 6 diopters, probably because this is the largest number of patients in this group as well. So what about how many patients we needed to reoperate for haze? So when we looked at our data of about close to 14,000 PRKs that were part of our electronic medical records, only 21 patients required repeat PRKs out of these patients. That's a reoperation rate of 0.15%, which is actually significantly low. And when we started to look at what was the cause of reoperations, we found that about a quarter were undercorrection, quarter was overcorrection, a quarter was residual power. So 75% because of refractive errors and only 28% because of haze. So only 6 eyes out of 14,000 actually required repeat PTK or repeat surgery for post-PRK haze. That's 0.04%, better than endophthalmitis as well. So the only interesting point is the fact that when you see patients who have higher myopia, they also tend to take slightly longer for them to come back to their preoperative best corrected acuity. Those who have higher astigmatism and high myopes, it can take up to 3 months for them to actually recover their vision to their preoperative level. So again, to get back to why surface ablation, again, like I showed you in the earlier slides, ectasia is something that all of us are going to face. We do not really know when it's going to happen or why it's going to happen. It's something like end off, and I believe that all of us do whatever we need to do to prevent end off, but we're not going to be 100% sure it's not going to happen to us. With PRK, you also negate several of the complications that happen with LASIK as well, and also because of the fact that it seems to be very predictable from the data that we have right now. And interestingly, most of our patients who come in for surgery right now, because they are word of mouth and they're referred by other patients, a lot of them actually ask for PRK by choice. And it seems to be a practice change that has happened, especially in Hyderabad, and that actually is something that is very heartwarming to see. And it is something that is more comfortable for the doctor as well as the patient. And I sincerely believe that when you do refractive surgery or any surgery, safety probably is the most important perspective that you have to talk to the patient about. And when you speak to them about this, almost everybody is willing to undergo PRK. And I'll end with a photograph of my cornea. That is my cornea actually. So I had PRK myself about 5 years ago, and you can see that there is no haze. And that is my cornea. If you want, you can have a look at it in the trade. So I was a -9 and a -1.5, and I would not have had PRK if I did not believe in it. And I am 2020. These are my reading glasses that I wear all the time. They're +1s. So this is something that I'm really happy about. And I also believe that I took this call after seeing several patients doing really well. And I think no regrets for PRK. Thank you very much. Yes, of course.
Do you have any cutoffs that you follow for every PRK patient? Like, for example, in LASIK, we keep a minimum RSB or the maximum ablation that you would do is such. Are there any such cutoffs that you follow, or it's customized depending on every patient?
Because RSB values are the same for PRK and LASIK, we tend to use the same correction. So absolute minimum RSB is 300 microns.
Okay.
I tend to stay above 325 if I can.
Okay.
Maximum ablation in PRK is 140 microns. I don't go beyond 140 microns. That's quite a lot already.
Yes.
Yeah.
Okay, and then when you said that over time or rather the higher myops take a little longer to settle, why do you think that is so? Is it the epithelium that is settling in, or as in why do we need to give them that much time for their preoperative BCVA to come back?
I think it's the epithelium. Really, nothing much happens in the stroma. So the epithelium relayering and smoothening actually takes more time in high myops, and especially those who have high astigmatism as well. So
Okay.
it doesn't seem to be something to do with stromal healing, but it's the epithelium that actually remodels over time.
Okay, and I think as Dr. Sahu has mentioned that preoperatively, I mean, we don't really test for vitamin D in every patient, but what are the things that you can see before? So the perfect score that they say, you should know what are the patients that may be exposed to haze. The numbers say that there are very few, but what can we do in a practical, scenario where we can say that, okay, a 9 diopter myopia, which is going to be treated, will not go into haze. So do we do anything beforehand, or just start a empirical vitamin D therapy or vitamin C? Any trips with that regard?
No, I don't think so. I think all you have to do is to be open to it. I don't think vitamin D and a lot of other factors really,
Make a
just like COVID, all of us thought vitamin C is preventive, so we started popping pills. This is something like this. This is like a shot in the dark. And I don't think there's any proof to actually say that vitamin C or D actually have a bearing on haze. We don't do anything specific for our patients, but I think there are three factors that are important. Number one is mitomycin C during surgery, like what Dr. Chinmay showed you. Number two is to ensure that you use low-dose steroids for an extended duration of time. And number three is UV protection. So these are the, I'm sorry? Steroids for powers that are above 6, we use for up to 6 months. Loteprednol once a day or twice a day if required, and for powers that are less than 6, we tend to use it for 3 months.
So have you seen any cases done PRK and surface ablation, and after a few years, like the patient was all right, he went to some, say, snow area or wherever, lot of UV, and he developed haze or something?
I think it's good to have UV protection even long term as well. We don't insist on it after the first 6 months when we follow them, because I don't think it's really possible to make a change in lifestyle to that extent. But I think it is useful to know about the risks of UV. I don't think we've seen patients who've had very late haze who've come back to us recently, at least.
Like for us, patients, people who want to join army or police,
Yeah,
they come and they ask for PRK and we do it.
true.
And so yesterday there was a course, and one lady
like I said, I mean, I put my money where my mouth is. So if I did not believe in it, I wouldn't have it. As simple as that. And I think it has to do with the steroid regime as well. For those who develop late haze, if you stop steroids early, I think the risk of developing haze late is actually quite high.
I mean, if you see the haze, do you put any other medications on? Like, is there a role of cyclosporin, or you just observe it?
No.
Observe.
Haze generally is better prevented than treated.
Treated.
Once you have haze, you can't really do much about it. So do everything that you can to prevent it rather than treat it later.
Commercial question: where do you get those circular merocils that you can put on the cornea for the MMC?
I don't use them anymore
No?
because they're
Or-
difficult to source. So all I do is put a drop of mitomycin C on the cornea, spread it evenly. Because the simple problem is you will not find a sponge that conforms to the shape of the cornea
Correct.
anywhere. It's only going to touch in one area.
Correct.
So put a drop of mitomycin C and spread it over.
It
So
doesn't
that way,
matter if it goes everywhere. It just
no, once
cold
you have your
wash.
cornea dry and you put a drop and spread it in the optical zone area, it's not going to flow away. It'll just stay there and then wipe it off after you finish.
Thank you so much.
You can again, but contact is a problem because it might not touch all the areas that you've ablated, but a drop ensures that you have contact in all areas, so it's simple.
Do we put cyclosporin routine for all PRK?
No, we never use cyclosporin. We don't use it. Yeah.
Can I
Any
button
difference
in just take
Sorry.
a couple of points out
Yeah.
there? For the point that you made, see, quite often what you do in practice is not because it's needed, but because it might help you in a medical legal situation. Now, when you look at LASIK, All India, the AIOS comes up with a recommendation of 480 microns. Now, you have people doing COVID studies and showing that the biomechanical strength. So the question out here is, if tomorrow one of your patient lands up getting it, and if at all he goes to a tertiary center. Now in India, Narayan Netralaya probably is now, sir out here obviously is there, but on the Shwin Amarish, Narayan Netralaya has maximum. And you saw the perfect study which they came up with. So quite often, I do it not because I think it's needed, but I just do it because in case I land up in the soup, it might help me. Number one. Number two, like there is no harm. Sometimes you just do it. It allays some kind of fears that you might be carrying. But I can tell you that with the smart surface ablation, I think haze is just out of the picture. We are regularly treating higher and higher myopes now. The second point which Pravin was trying to make was he's mentioned that up to 3 months is what they have seen, the corrected visual acuity to come by. Actually, yes, it takes the epithelialization takes a bit of time compared to the lower myopes, but the UDVAs, if you call them at 2 weeks, and if you call them at, and I think it's mainly to do with the dry eye part of it. More than anything, it's just that the tear film is stabilizing in these patients. At 1 month, I think bang on, most of these patients are 6-9 or if not better. I wouldn't say that 3 months is the period that you're looking at. Third part was, ma'am, in terms of what sir does is he applies a drop of mitomycin. I've tried with the Veckels, the merocil sponge that you talk about. But what we do is we take a bit of cotton. The sister just kind of, a circular manner cuts it. We dip in mitomycin, squeeze it out completely, and we then place it on the cornea. This, to my mind, is helped me a lot. Earlier when I was using the sponge, one part you've applied, the other part is dried up. You don't know whether you're evenly applying it to the surface. And the other worry of the mitomycin going into the conjunctival surface and causing a lot of inflammation or irritation. So when you do it with a cotton, squeeze it out and apply it on the surface, it takes care of any kind of irritation or those concerns that you could have. And we don't use any cyclosporin routinely. It's only yes, if you see a little bit of haze happening, now no one knows. Once you start seeing, as sir said, that haze is better prevented rather than managed. But once you start seeing it right from oral steroids to Talimas to using cyclosporin, it's anyone's guess, whatever. But telling patients, one thing we noticed was this outdoor UV light exposure, which you say, the UV light. At least for the first 3 months, we are very strict with our patients. We recommend them not to go out when, and do outdoor activities when the sun is out, or to use UV protective glasses if they're doing it, though we strongly, discourage that.
Which of the platforms, like Schwind versus Streamlight, which one are you using, and any obvious pros and cons?
But before I actually say something about that, I think Chinmay, the question about patients getting better, I think to be realistic, this I can't see my slide, but it's not about what I think or what you think, but this is data from several thousand patients. So what you say is
the
true.
The papers which I had shown were actually studies on the Schwinn Amaris.
Correct.
In the multicentric study, the meta-analysis of 1924 eyes,
Yeah.
actually at 1 month, the uncorrected visual activity was close to 94%. That means your best corrected upon your uncorrected, the pre or post-op, it was 94%. So that was a 1 month figure which they mentioned. So I think the jury is out there. Frankly, data is out there and data is equivocal. You could skin it both ways.
Yeah.
But on practically what I've noticed in my patients is what I mentioned actually.
That's true, and I tend to agree with you. So what I said was recovery of vision for high myopes
Yeah.
is what takes time,
I'm not-
and not the low myopes. Up to 6 diopters, I think in a month,
Yeah.
the majority of them are at 20 by 20. But for those who are higher myopes, because of the fact that, like you said correctly, I think it's a dryness as well that has a
Role to play out there.
Yes, but then the simple question is when you ask them to put a drop like Optive on the eyes and then see if the vision improves or not, that usually is an interplay between the smoothness,
Absolutely.
adequacy of the tear film and the epithelial thickness as well. But going back to your question, ma'am, about the platform, I think everybody is going to be speaking about the platform they use because that's the one that they know the best. I really do not think one platform is better than the other. And I think as a group, I think it's the PRK that we are all voting for right now to say that this is a procedure that can be as good as any other refractive surgery and is safer than what we are currently doing in LASIK. We use
Actually,
the wave light.
that's the point that I would like to make.
Yeah.
When I started with refractive, I'm a trained retinal surgeon. In fact, was a consultant in retina at LVP Hyderabad for a while. So when I started, I had no background in refractive and I was doing 70-75% lamellar procedures. So when the blade, the microkeratome is new, you never see flap-related complications. It's as when you keep using it over a period of time, you start noticing. Third, fourth year of my practice, I had my first few flap complications. And believe me, my heart sank. When you deal with your flap complications, a flap wrinkle, a flap, when you develop any kind of buttonholing and then you have to manage epithelial ingrowths, that's when I actually started migrating to it. So I would start by saying that do no harm should be the first motto of any doctor or any procedure that you do. You're doing a procedure and a person who's a BCVA prime almost of 6'6". So if you meet a problem after that, it becomes difficult to handle that. So, and surface ablation is, people want the wow factor and doctors keep coming to my center and there is no wow factor in PRK. What I want to do is debunk these myths, come out with data which shows that it's equally safe, predictable, and if you counsel the patient adequately preoperatively, all my patients today go for PRK. And the one big thing that happened when I interacted with Rohit was that I started charging almost 25% more for my surface ablations. So it takes away from the patient's mind that you're doing something inferior. It's actually something that the machine allows you to do because of its superior technology and should be charged adequately.
Yeah.
Sir, could you please about EX500 or everyone is talking about Schwinn only?
My laser platform is EX500. And like I said, I don't think the platform makes a huge difference. I think they're all the same.
Yeah.
So could you please elaborate on post-op
Yeah.
treatment,
So-
when to start steroids, when to remove the BCL, and
Also the
are there chances of
lotiprednol.
infection in trans-PRK?
Yeah, I think again, practically, steroids, what we start is we start the first drop of steroids on table. So the patient gets a drop of steroid as soon as the surgery is done. Steroids started on day one. We start with lotiprednol 4 times a day and then taper weekly and keep them on twice a day for about a month. After that, if the power is high, I'll keep them on twice a day for up to 3 months and then cut down to once a day for 3 months after that, so 6 months. If the refractive error is less than 6, then they stay on 1 time a day for 3 months. And if required, then I continue them slightly longer. If they have allergies or if it is summer, then I tend to use it 1 time a day for a longer duration. Antibiotics till the epithelial defect heals. BCL typically at 1 week. Earlier, we used to be very worried about infections and we used to see patients very frequently. Now we don't see them till the first week post-op. We do a teleconsult online, so we actually save a visit for the patient. 1 week later, they come in, we remove the BCL. Also, we don't give them the opportunity to complain about the pain if we don't see them early. And after that, they are the artificial tears for 6 months or so.
So,
No, in fact, one of the faculty members at our center uses prednisolone 2 hourly. All that does is cause more glaucoma, but it doesn't seem to increase or reduce the incidence of haze because we looked at numbers. and we found that the haze was just the same if you use lodiprednol or predpone.
At
So-
our center, we are using, we don't use steroids for the first 1 week, especially for myopia up to 6, because we don't want to take the risk of infections. Everybody has the stress of BCL there. So we start the steroids only after 7 days after removal of the BCL, and we have not found anything different in terms of the final outcome. Also, because of MMC, it has made a huge difference. The third thing I would wanted to point is for Tanvi, we use a cutoff of 470 at our center. In some cases, we've gone up to 450 also in low myopias. And the other thing I would say is that in high myopias, because of epithelial hyperplasia that sets in, we tend to use, as sir said, using of steroids for a longer time. It helps because of epithelial hyperplasia. Patients tend to have some induced refractive error, and they are not very happy sometimes. And we just continue the steroids, lubricants, and we reassure them we don't have to do retreatments. And by 3 months, they usually settle. And for that reason, for higher myopias, you tend to have slightly longer duration. But again, for high myopias, we use a slightly larger transition zone. We smoothen the edges, and we tend to get faster epithelial healing. So that additional point can be done for high myopias. Thank you.
So, Pravin, if I can ask you, the summary is that PRK on the one hand is higher safety, no flap complications, less risk of ectasia, whereas the wow effect of LASIK generally we don't see with PRK, and there is a risk of haze. So today, if some patient comes, whom are you likely to advise for LASIK over PRK, or is there no category which you would recommend either LASIK or SMILE over a PRK, or your standard to go is first PRK and otherwise these two categories?
We have 2 femtosecond lasers, and we have Visumax as well. So if I advise everybody who comes in PRK, then I think that's not great business sense, right? So in fact, everybody who comes in and is completely suitable for LASIK, if they ask for LASIK, we do LASIK. We don't dissuade them from undergoing LASIK because, that's how it works, right? It's only that if I have any hint of doubt that this is a cornea that either is not normal, somebody who's really young, or borderline, then I always plunge for PRK. But if a patient puts me on the spot and says, if this was your eye, what would you do? And then I say I would do PRK.
Okay.
Yeah.
So, just one follow-up question. This, me included, a lot of people, I think that cutoff is -4, and anything more, they will say that, look, we can do a PRK, but be prepared for haze or, certain complications in the future. That is totally out of the picture from what I understand from you.
It can't be totally out, but how many cataract patients do you speak about endophthalmitis? We don't, right? So.
Yeah.
The flying spot laser has made a huge difference.
Okay, thanks.